Hello, everyone, and thank you for joining us today for the Department of Public Health Project Echo Cancer. We are delighted today to have you with us, and we were just going to try to wait to officially start around 12:05 just to give any other folks who may want to join us the opportunity to do so. It is lunchtime, and folks may be gathering just a few more things to get settled in, and so we'll give it about 2 more minutes and we'll get started. While we are waiting, I would just ask if you would in the chat in a few moments before definitely this session ends, we'll have an evaluation link for this session. And if you would take a moment to give us some honest feedback, that is how we improve our sessions. Or if you have any comments for future topics, we would be delighted to look into that. Would also want to remind you that we have a Project Echo website. If you simply do a search for DPH Project Echo, you'll see our website that has other recorded messages. So if your colleagues are not able to make today's session, it will be uploaded to that website. And Dr. Hayes, is that okay that we record your session for later viewing?
Of
Awesome.
course.
Thank you. Alrighty. And reminder that there are CMEs that will be provided for all sessions, including this one. And um, again, if you have any questions about the continuing credits, just email us at projectecho@dph.sc.gov. Okay, by my computer clock and both of my phones, it is 12:05. So let's get this session started. So let's start with an introduction of today's speaker, Dr. Marie Hayes. Dr. Hayes is an assistant professor in the Department of Psychiatry at the Medical University of South Carolina, known to most of us as MUSC, where she serves as a licensed clinical psychologist in the Women's Reproductive Behavioral Health Division. She earned her MA and PhD in clinical health psychology from the University of North Carolina at Charlotte. Completed internship at Duke, including rotations in reproductive psychology and psycho-oncology, and a postdoctoral fellowship in psycho-oncology at the Levine Cancer Center. Her work centers on reproductive behavioral health, with particular emphasis on infertility and substance use, and leveraging technology to improve outcomes. At MUSC, Dr. Hayes is the director of Moms Impact, IMPACTT, the Prenatal Psychiatry Access Program for South Carolina, and a SCORE scholar studying ways to improve dissemination and implementation of guideline concordant reproductive behavioral health screening and care for cannabis use during pregnancy and postpartum. Today's learning objectives include understanding the impact of potential loss of fertility because of cancer treatment on mental health, considering ways to support reproductive age patients facing fertility impacts because of cancer, deepening awareness of the role of fertility preservation. I cannot get that word out. Forgive me, Dr. Hayes. Education in delivering whole patient focused care. And finally, appreciating the various ethical dilemmas related to this topic. Dr. Hayes, I will hand the mic over to you and we will be listening intently. Thank you again.
All right. Thank you so much, Sonia. I'm going to share my screen. Are y'all able to see that? Did that work? Yeah. Okay.
Yes, I'm sorry.
That's quite all right. So thank you for the warm introduction. I'm excited to be here. This is one of my favorite things to talk about. I have a pretty strong background in psycho-oncology, and I'm now in the Women's Reproductive Behavioral Health Division here at MUSC. And so this topic is like a merging of many of my passions. I do not have any disclosures other than to say I am a clinical psychologist, not a physician. We'll go through some kind of basic foundational information that's more medically related about fertility preservation. This way everyone understands what I'm talking about when I say that. But I like to include this disclosure before we go through those slides. And I'm going to skip through these for the sake of time and because we already went over the learning objectives. So, as you can see in the United States, the age at which people are giving birth is almost 5 years older in 2022 as compared to 1970. And if we look at the age that an individual is the first time that they give birth, so the number of people giving birth for the first time between ages 40 and 44 has more than doubled since 1981. So folks are having babies later in life. And we know that there are a number of reasons for this. But what does that mean as we think about this from kind of the cancer spectrum? So at the same time, you'll see on the right-hand side that primarily the rates of cancer diagnosis for males aged 0 to 49 have been like relatively stable since 2000, whereas you'll see the rates of female diagnoses really have increased from 2000 to about 2022. And the stats on that is the incidence is 82% higher than male. So there's a pretty significant discrepancy between the number of folks who identify as male versus female being diagnosed with cancer during this younger age cohort. This is for a number of reasons, primarily due to increasing rates of breast cancer, also thyroid cancer, but that has kind of stabilized and gone down a little bit actually in recent years. So folks are having children older and women are being diagnosed more frequently at younger ages. The good news is that 5-year survival rates from cancer diagnoses have gone up across pretty much all of the primary tumor sites. So that's fantastic. We want folks to be able to live longer and be able to recover from their disease. But we also have to think about what life and living life looks like and means as the survival rate is increasing. So when we think about the adolescent and young adult population. So AYA is the abbreviation, if you're not familiar with that. And these are primarily individuals who are diagnosed prior to like around age 30-ish. We know that there are unique concerns that come up with their diagnoses and treatment and adjusting to life both during treatment and also in survivorship. And these often are co-occurring and interacting with one another, and really, really complex relationships start forming to disrupt the lives of these patients. And we're going to be specifically focusing on the role that fertility plays in today's talk. So when we think about this, we have to think about the impacts from disease, the disease itself, but also all of the treatment impacts that happen, which of course we want to be able to treat the disease and support life after disease. But oftentimes, as again, many of us know, these treatments have many impacts to life outside of just the disease state. So the tumor itself could create damage to reproductive organs in the tissues, the organs themselves. There can also be endocrine disruptions that happen as a result from the primary disease. This could be, for example, like in the ovaries or pituitary glands if they are damaged due to that disease state. But I think more often when we think about oncofertility and fertility preservation, we really start thinking about all of the subsequent treatment impacts that could happen. So of course, there are like the surgical treatments that happen that remove reproductive organs that we need to be considering. We also have to think about impacts because of radiation therapy. And I think many folks think about this in context of radiation being specifically delivered to like reproductive organ areas or kind of the neck area. But we have to think about total abdominal kind of radiation or whole body radiation too, in terms of like the impacts that those can have. This is very dependent. So damage to the ovaries that can happen is very dependent on the dose, the field, and kind of the age of the person. So there's a lot of individual variability that's going to happen in terms of impacts. But I think it's helpful to be aware that generally there are different kind of mechanisms through which fertility can be impacted from treatment. We can also think about radiation to the brain that sometimes can have some downstream impacts to like pituitary gland. And this may or may not impact fertility. It really depends again on some of those individual dose and focus factors. One of the, I think, primary areas that we think about from damage from treatment is often, I think, because of chemotherapy. So some of these agents that actually work to kill cells, those cells that rapidly divide in our body, that's usually what a number of chemotherapy agents target, which includes cancer cells, but this also includes the cells of like your reproductive organs. So for example, your eggs, those are organ cells that rapidly divide. So those can be targeted through some of those agents. There are also impacts that happen again to the hormones that are involved in the reproductive process. And we can either experience kind of loss of being able to produce those hormones or damage to how those hormones are produced. And these can be temporary changes or they can be permanent changes. So just being aware that there are many, many factors and ways in which treatment can have some impacts. And a lot of this is going to be dependent on the agent. It's going to be dependent on the person and kind of what their specific treatment plan looks like. Another thing that I just want to point out is particularly for folks with female reproductive organs or women, even if they don't experience kind of immediate ovarian failure and they continue to menstruate after their chemotherapy, these individuals are very, very likely to have reduced ovarian reservation, so fewer eggs in their ovaries. And higher rates of premature ovarian failure. So just because somebody completes chemotherapy and they're still menstruating doesn't necessarily mean that they haven't had impacts because of impacts to their fertility. There are medications that are more likely to impact fertility, particularly in women than others. If you are interested in a list of those, I'm happy to send those out, but I'm not going to hurt everyone's ears with trying to pronounce all of these medications because I am not an MD. So when we think about this, we want to think about this from the perspective of all of the players. And so, of course, the kind of patients come first to mind. We'll also think about this from the perspective of family members and from providers and those who are responsible for treating this patient and caring for them. We know that fertility is extremely important to patients. The data on this topic indicates that potential loss of fertility has actually been found to be just as distressing to patients as the cancer diagnosis itself. And so this is a tremendous kind of loss that folks are potentially grappling with right around the same time of diagnosis. And so we know that up to 3/4 of women who are of that reproductive age are often interested in potentially having children in the future. And a lot of folks like really rank this as being very, very high. Number of people indicate that loss of fertility is one of the most important or most concerning impacts on their overall life because of their cancer and its treatment. We also know that impacts to fertility can influence treatment decisions. And so this was reported by almost 30% of female breast cancer patients in one study. And actually, a number of folks indicated that they were considering either not receiving treatment, reducing their dose, or reducing kind of the course of treatment or the number of sessions that they would complete, or changing the agent or any maintenance therapies that they might be doing because of concerns about fertility loss. And so sure, 1 to 11% over the course of 100%. Like that's not everybody, but that's a pretty significant number of people, especially if we're thinking about folks who have like a pretty treatable disease, might potentially have some negative impacts if they are deciding that they would like to change some of their treatment course because of concerns about fertility. So what do I mean when I'm saying oncofertility? I'm just talking about being able to maintain fertility during cancer treatment. And so, of course, this is going to be different for individuals with male reproductive organs versus female. There are some shared options. But we know over the last 30 years or so, this has become a very, very important topic, and awareness about all of those negative impacts that I just reviewed has really expanded. And so a number of organizations have recommended having conversations with patients about oncofertility. The Oncofertility Consortium was formed in the early 2000s, and this is institutional, kind of interdisciplinary consortium. They run a conference, I believe it's every year, that they run, and their goal is really to expand information, access to treatments, access to awareness around fertility-related concerns because of cancer. They more recently expanded that definition to include concerns resulting from non-malignant diseases, but their primary focus is still from an oncofertility perspective. I said this earlier, and we'll kind of be talking about this throughout, and this might be something that popped up when you heard that I'm a clinical psychologist and not an MD. Why is this person talking about oncofertility? I thought that was a medical process. And that's because the process of fertility preservation and the topic of oncofertility really, really is a collaborative and interdisciplinary field. So we need collaboration and quick collaboration by that from oncology, psychology, reproductive medicine, andrology, cryopreservation, and folks who have financial counseling information. We can include the nurse navigators and care navigators in that. There are like a number of different specialties that have to move quickly to be able to support oncofertility. And so the focus of the Oncofertility Consortium has really been to kind of expand those relationships and increase awareness to the interdisciplinary nature. When we look at differences between males and females when it comes to oncofertility, we know that for males, the primary barrier to being able to access fertility preservation is patient knowledge. And that can be addressed relatively easily by increasing that knowledge and disseminating that knowledge. When it comes to females, this gets a little bit more complicated because we know that the number of gametes that are available in a female reproductive system are limited. They're not unlimited, they are limited in nature. They mature on a cycle, so part of that kind of monthly menstrual cycle. And we need to be able to retrieve them surgically, whether we're retrieving eggs or we're retrieving tissue. So it's more invasive of a process. That also means it's more expensive of a process. And so that's another barrier that comes into play. From the medical side of things, for both, to some degree, we need advanced knowledge, of course, skill sets, and access to equipment to be able to retrieve and store anything that's going to be preserved. But this becomes even more essential and complicated when we're thinking about having medical procedures and surgical procedures for women. This next slide just offers, this is like a very, very high level overview of some of what is available when we think about fertility preservation. So the method that's available for both men and women is embryo cryopreservation or embryo freezing. And this is just creating embryos, so retrieving eggs, retrieving sperm, creating those embryos, and then storing them for future use. This can take about 2 to 6 weeks. Again, we're somewhat dependent on the cycle of the female body. There are considerations when we're thinking about estrogen-sensitive tumors because of the medications that are used to stimulate egg production and maturation to be able to retrieve those eggs. So there are some kind of treatment considerations there. there are a lot of ethical considerations. So as we kind of talk about things today, I'll sprinkle in some of the ethical thoughts, and we can talk about it more in Q&A if that's helpful, because there are so many ethical decisions that have to happen during a really stressful time. So, for example, think if your patient is unpartnered. So the success rate you'll notice for embryo freezing, and this is a success of a live birth, are the highest. However, if you don't have a partner, then you also have to involve donor egg or donor sperm to be able to create those embryos. If you are partnered and you're able to use both of your gametes to create those embryos, we have to think about future divorce. And usually there are legal contracts in place at the time of preservation. What happens if there's divorce? What happens if there is death, either from the patient with a cancer diagnosis or the partner, or potentially both, who has access to those embryos, who can use those embryos. And of course, there's a significant cost that comes with this process. When we're thinking about female patients, we can think about egg freezing or oocyte cryopreservation. This is retrieving and storing mature eggs. There are different protocols that can be used depending on how time sensitive. Of course, like starting treatment is always going to be time sensitive, but there are some treatments that the data indicates that delaying the treatment by 6 weeks is not necessarily detrimental to overall outcomes. There are some tumor types that are going to, like the estrogen sensitive tumors, that are going to be particularly sensitive to the stimulating hormones to create and mature those eggs. So there are some different protocols that could be implemented. There's variability and option there. Something to think about is so when you are freezing eggs, the process of freezing, there are a few different processes that can be used in the process of freezing eggs and then being able to unfreeze those eggs in the future. Those processes have to be aligned. So for example, if somebody were to be using like donor gametes, there might be specific labs that a clinic works with and others that they don't. And that usually is because of that freezing thawing process. So that's something that has to be considered. Just because you freeze eggs in 2025 doesn't mean that the lab that you want to use in 2028 or clinic has access to that, the technology and software to be able to unfreeze those eggs. One thing is that no partner is required to complete this process. And so that can be an ethical consideration as well, kind of depending on a patient's personal beliefs. This is a little bit less successful when we're thinking about live birth rates, and many different factors come into play here to impact that range of 24 to 60%. Sperm banking is the primary kind of preservation technique for people with male organs, reproductive organs, or men. It's retrieving and storing sperm, freezing the sperm. This is the only recommended fertility preservation method for men, and success rates are high. I mean, there are some ethical considerations in terms of partners, and there can be some factors that come into play, but this is like pretty straightforward and pretty effective. When we think about maybe folks who are of younger age, so we're thinking more like children who are diagnosed, there are some ethical considerations about sperm banking and retrieval. There are processes to kind of retrieve sperm for folks who are younger, but of course everybody has to be able to create sperm to be able to retrieve and freeze that. So those are some considerations. And then you all may or may not have heard of tissue preservation. This has become a lot more popular in the last few years, and I think is more talked about in the literature. It's still considered experimental, but this could be potentially an option, especially for children who have not yet reached puberty. So their bodies haven't yet started to make and release eggs and to make and release sperm. Other considerations, especially for women who are diagnosed with cancer, is who will carry a future pregnancy. So maybe they were able to store eggs or store embryos, but their body is not able to carry that pregnancy to term, or it's particularly risky. And then so there's an additional kind of factor of surrogacy, which can be extremely expensive, on top of all of this expense that's already been paid. So they're just like, that's a smattering of some of the different options and kind of questions that we have to be considering when we're talking about these with patients. So as we all know, we don't just treat an individual at the time of diagnosis and until their disease is in remission. We also consider the spectrum of cancer and kind of that whole person approach to include survivorship. And so reproductive health and survivorship, it kind of ranges from a number of different things. We'll be focusing, of course, on family building and fertility in this talk, but it also includes like sexual functioning, impacts to body image. There are a number of changes that impact reproductive health in survivorship. So we know, unfortunately, that rates of pregnancy among cancer survivors generally are lower than their age-matched peers. This might be because of a number of factors. And there isn't a whole lot of research. So in this area, it's less researched than reproductive health outside of the cancer population, which is an under-researched area in and of itself. But generally, we know that fertility treatment success is less studied in this population, but it's thought to be similar to folks who do not have that oncology history. So that's something that is kind of helpful. And when we're thinking about fertility preservation options, we can kind of look at the general population data. We know that there's a theoretical risk of pregnancy and like all of the hormonal changes that happen throughout pregnancy, creating an increased risk for recurrence. But this is not something that's been supported in data and in the literature. And so I think that's also really important, that sometimes both providers and patients and their families are thinking about. It's not something that's been shown in the literature in larger scale data sets too. And then that kind of who will carry the pregnancy that we talked about in that last slide, and then the cost of that. So we also have to think about not just kind of the physical self, but the psychological, emotional self, quality of life. So there is a significant psychological morbidity that happens from diagnosis. It kind of persists and changes a little bit, evolves throughout treatment, and then into survivorship, more of like that fear of recurrence and kind of coming to terms with quote unquote the new normal, which really resonates with some folks and really does not resonate with other folks. So that trajectory can change a little bit. When we think about this from the context of fertility and impacts to fertility itself, we know that unmet fertility education, all of that, if somebody did not have access to that education, they are more likely to experience higher levels of distress. They are more likely to experience regret, have kind of a negative outlook and poorer kind of overall emotional quality of life. There are interventions and studies that looked at what happens if we just give people information, and we do see that the distress in survivorship is actually lower with having information, even if somebody does not pursue fertility preservation treatment. So really that like kind of regret, remorse is happening from folks feeling like they were not a part of these decisions. They were not given the information to be able to access what is the best decision for them and their families. We also have to think about the intersection of maternal morbidity and mortality, particularly from a mental health standpoint, having an oncology history. And so when we look at some of this data from the United States, unfortunately, the US is the worst in terms of morbidity and mortality during pregnancy and postpartum than any other developed country. We're pretty significantly worse off than other countries. And if we look at this by race, we'll see even larger disparities with Black individuals having even poorer rates. And that's even while controlling for education, socioeconomic status. And so Importantly, mental health conditions are the leading cause of death, pregnancy-related deaths. And so we have to be mindful that having oncology history, having maybe potentially not having access to fertility preservation or information or education or procedures themselves potentially can impact and have some compounding effects on some of those morbidity and mortality outcomes. There's not a lot of data. There's actually, I couldn't really find any studies on this. There is the theoretical kind of idea that being a survivor could be a protective factor. I worked really hard and I've been through a lot of things, and I can handle postpartum kind of having a different outlook. But that hasn't been studied yet in the literature. I think that would be really interesting to see resiliency and how to foster that. So we already talked about this. So I've been briefly kind of alluding to this and touching upon this as we've been talking, but thinking about the role of education and also shared decision making. I mean, we talk about shared decision making in so many facets of medicine and treatment planning, but I think that comes up and is very pronounced here in this process. So education, and remember, it's regardless of whether or not somebody even attends an appointment with somebody with an REI, a reproductive endocrinologist. This is just having access to that information. It's consistently associated with improved decision-making on fertility preservation, less regret, less decisional conflict, and better coping with the burden of cancer treatments. And this has been shown into survivorship as well. Positively associated with social well-being, so exposure to that education, positively associated with social well-being, less distress, and just overall reporting a higher quality of life and survivorship. So this kind of patient-centered approach using shared decision-making and having education on fertility impacts and preservation options really does have a pronounced impact on quality of life in the long term for these individuals. And so unsurprisingly, as a result, many of our major organizations have released guidelines, ASCO, to include oncofertility or fertility preservation information as part of the practice. ASRM, which is the American Society of Reproductive Medicine, includes this and also goes into more information and recommendations on best practices and an interdisciplinary approach in their guidelines. So in practice, unfortunately, we know that this is not happening often. And so females, one study showed 26% up to 68% received fertility counseling. And this is because of a number of different factors, which we'll talk about briefly. We know that this is not just specific to women, that men also do not receive information on sperm banking, even though many of them indicate many oncologists indicate that this should be offered. When we're thinking about kind of disparities, particularly for women, we know that pediatric patients, there are disparities that start happening when we think about education, cancer type, age, I think a lot of the traditional disparities that we see in accessing healthcare show up here as well. So Latina and African American patients are less likely to undergo preservation than their white counterparts, and lower income, Medicaid insurance, or older age are also less likely to be offered counseling when we're looking at men specifically. And so this is not even being able to access treatment, but just those who are offered information about treatment. So this is for a number of factors, a number of different levels and kind of barriers that exist. We already know that patient knowledge is a barrier, particularly for men. But we also know that there are some barriers that pop up in terms of like not being able to access providers, not being able to access cost coverage. Insurance in South Carolina does not, as far as I know, does not universally support fertility preservation. In some states, it does have to. It's required to support at least some degree of that, but not in South Carolina. We know that there are limited referral pathways for providers. So providers will often report like, okay, what if I bring this up to my patients and then they do want to go meet with an REI or a fertility clinic? I don't even have anywhere to send them. And wait times to get a new patient appointment at a fertility clinic could be 6 months to a year. So that's definitely a real barrier. Providers feeling like they don't have enough time in an appointment. There's so many things that need to be discussed, especially like around the time of diagnosis before starting treatment, and feeling like this one is just not on the higher end of priorities. It is important, but we have to talk about all these other things, and I'm only allotted 15 minutes or 30 minutes. We know that stigma, discomfort with this topic pops up, particularly when we're working with children, pediatric patients. Sometimes ethical concerns can come into play. And then all of the health system barriers. I mean, we've been talking about these in terms of cost, access, being able to hold appointments, particularly for this population, and like all of the, if you're working in an RVU model, the downstream effects of like, if those don't get filled. So there are just a lot of barriers to overcome at a number of different levels. So very quickly, we'll touch on some of the ethical considerations that we haven't already touched upon. We've talked a little bit about adolescence in terms of the kind of being able to retrieve gametes, but there's another kind of ethical consideration in terms of including parents and guardians. And I think adolescents who are a little bit older, who maybe kind of understand what goes on. There's kind of this embarrassment and shame that can come up. But of course, like ethically, we are responsible to include parents and guardians into these conversations. When we think about mortality too, this is something that comes up sometimes in when fertility clinics have these panels and talk and kind of think about decisions and patient cares and special circumstances, but like mortality. If somebody who maybe is diagnosed with stage 4 cancer, their prognosis is not looking good, but they would like to pursue fertility preservation, what does that mean then for the potential child that's brought into the world without their parent? Or what does that mean in terms of if it's like a highly heritable cancer? And we're now like kind of using medicine to be able to create embryos or create new lives to perpetuate that gene pool. And so something that like from an evolutionary perspective maybe is more natural selection, now we're using medical involvement to intervene. And so these are like very, very, I think, loaded ethical questions, and we need to be able to have conversations about them as professionals and understand that things kind of do vary on a case-by-case basis. I don't think that there are like right or wrong answers for any of these questions. We already talked about the relationship status. So if you create embryos with, at the time, your husband, and then you guys get divorced, and now you do not have the opportunity to create any more eggs in your body. And those are the only embryos you have, but you're remarried. And do you want to have children with somebody who is biologically kind of has the genetics of your ex-partner? Like there are so many dynamics that can pop up. And we also have to think about like the storage of those gametes and embryos. There are storage fees that are involved on a monthly basis. What happens? How do those get disposed of in at some point in the future? This bigger question of like, who is responsible for determining whether a child can be born, right? Just because we have the technology and the medical knowledge to be able to do it, who gets to decide, is that something that we should be doing or should not be doing? Like, who is doing that gatekeeping? And then we have to think about too, all of the additional challenges that pop up that are associated with being a parent in the future and survivorship, these like existential concerns about whether they'll be alive to watch their children grow up and the impacts that happens on our patients, but also on their offspring. So these are like some kind of really loaded questions, and I don't think that there are clear-cut answers for any of them. There are recommended guidelines for having education and fertility preservation conversations with patients. There are published ones. Up at Duke, they've done a really good job. Northwestern has done a really good job with this. I will say, though, that both of these institutions have cancer centers and fertility clinics within the same healthcare system. And so I think there are a number of barriers that are introduced when that does not exist. So for example, at MUSC, we do not have REI or fertility within our system. And so any referrals have to go to an outside system. I'm not sure how some of the other major hospital systems in the state work, but that is something to consider. The recommendation is to provide fertility education or counseling to reduce that future regret, to improve quality of life, regardless of if somebody is going to pursue preservation or not. We want to make sure that we are empowering patients to make informed, educated decisions that are personalized to them. And then if we need to figure out a way to operationalize like treatment referrals, all of that is kind of downstream to having the education for patients. I don't know if this is in the literature or not, but I don't know that it's like the greatest idea to be doing all of this education without having any fertility clinics to send patients to. But I think fortunately, we're not in a state in our country or place kind of a time-based state, like a physical state in our country. I think that there are fertility clinics throughout the country. Some are just more readily available than others. And just wanted to end with emphasizing that the goal of fertility education and counseling is not to increase the rates of fertility preservation that may or may not happen. It's to make sure that patients are actively informed and involved participants in their care and in their treatment decisions to improve their quality of life.